Okay, so the local anesthetics. So we're going to talk about basic anatomy and physiology of the nerves, how they work, chemistry behind them, their activity, various additives that we can use to affect the function of local anesthetics, the pharmacokinetics of these drugs, how we use them clinically, and most importantly, their toxicity. So starting with anatomy and physiology, talk about the most basic nerve anatomy. You have your nerve fibers, and these individual nerve fibers are surrounded by an endoneurium. Then these come together and are surrounded by perineurium. This is your nerve fascicle. And multiple nerve fascicles make up the peripheral nerve, which is then surrounded by epineurium. Now, the important thing to understand is that there are three layers of connective tissue that local anesthetics have to diffuse across in order to hit the nerve. And typically, when you give a dose of drug, only 1 to 2% of this drug is going to hit the nerve. Okay, now you have myelination. Talking about the peripheral nerves, not all are myelinated. The A and B fibers are myelinated, where C fibers are not. And unmyelinated nerves tend to be more resistant to local anesthetics, so they tend to be blocked last. Okay, then you have different size nerves. The larger nerves tend to conduct faster, but they're also harder to block. So the size principle states that the smaller nerves tend to be blocked first by local anesthetics. Now this is a nice table from Barish showing the different types of nerves. You have your A, B, and C fibers. The A and B fibers tend to be myelinated. C fibers are not. Then you have the different functions of the nerves. And because you have this differential blockade of based on size, based on myelination, we get what's called the differential conduction blockade. So when you give your local anesthetic, there's an order to which nerves are blocked. So first, these smaller myelinated nerves are blocked. And these tend to be the B fibers, the A delta fibers, which mediate sympathetic function, temperature, sharp pain. Then we block the larger myelinated fibers. These are the A alpha, A beta fibers. See a larger diameter, myelinated, mediate motor proprioception. Then lastly, you block the smaller unmyelinated fibers. And these are the C fibers, which mediate dull pain. And you can see that the unmyelinated fibers tend to be more resistant to the local anesthetic, and usually these small unmyelinated fibers are blocked after the large myelinated fibers. And this sort of violates the size principle, but it's due to the effect of myelination. And overall, your order of which features you block tend to start blocking the sympathetic response, then sharp pain and temperature sensation, and then you block your motor proprioception, pressure, and lastly your sense of dull pain from these small unmyelinated fibers. So basic nerve physiology. Typically nerves are negatively charged, about minus 50 millivolts. This is the interior relative to the exterior. And when a nerve is depolarized, the interior of the nerve becomes positive, and this positive action potential propagates down the neuron. Now, this action potential is propagated by sodium channels. Now, sodium channels tend to be in the resting state. Now, when they sense depolarization or charge, they open, and this opening allows for positive sodium ions to come into the cell. And then once the channels have been open for a short while, they'll change to the inactive conformation. And when inactive, they'll be refractory, and no sodium will be able to enter through those channels. So how do local anesthetics work? So we just talked briefly about the sodium channel, and the local anesthetics modulate these sodium channels. Now, local anesthetics are weak bases, which means they can accept a hydrogen, become protonated, but in order to cross the lipid bilayer, they need to cross in the uncharged form. So they cross uncharged. Once in the cytoplasm, they pick up a hydrogen, become protonated, charged, and they bind to the active site in the inside of the cell, to the sodium channel, and prevent its function. So there are two basic types of block, a tonic block, use-dependent block. So the tonic block, very straightforward. It's a dose-dependent block of sodium channels. So you give more drug, you have more block. Very straightforward. Use-dependent blockade basically relies on the fact that open sodium channels are bound more tightly by local anesthetic. So by repeatedly stimulating a sodium channel, it will be in the open conformation more often. And therefore, local anesthetics will bind to it better, and you get a larger block. Now, there are two theories as to why this may be true. There's the modulator receptor theory, which states that whenever the channel is open, the conformation of the binding site changes so that the local anesthetic binds to this binding site stronger. The guarded receptor theory states that the binding site is actually blocked by some barrier. And when the channel is in the open conformation, that barrier is removed and open to be bound by a local anesthetic. So also the amount of drug you use is important. You have to use a sufficient concentration to actually block pain. And keep in mind the differential conduction blockade. There's an order as to which nerves are blocked, and you want to make sure you block the pain response. Also, you need a sufficient volume to block the nerve impulse. If you use a small volume of drug and you block a small portion of axon, the nerve potential can actually get around that nerve block. And you need a sufficient length of axon blocked to actually stop the action potential so it does not propagate down the length of the axon. Okay, so the chemistry of the local anesthetics. First, we need to talk about the structure, and then the two main types of locals, the esters and the amides, and then lastly get into some acid-base. So overall, the structure relates to the function of the local anesthetic. Over here you can see a benzene ring. This gives a local anesthetic its lipophilic nature. This is what helps it dissolve through the lipid bilayer of the nerve and actually get into the cytoplasm. Now moving to the middle, there's this intermediate chain which links the benzene to the amine group, and this chain defines whether the local is an amide or an ester. Now over here we have the amine group, tends to be a tertiary amine, and this makes the anesthetic a weak base. This tertiary amine is capable of accepting a proton, although weakly. And the amine doesn't always look this simple. There can be an additional alkyl groups on there, which may help to make the local anesthetic even more lipid soluble, so it can more readily dissolve through the lipid bilayer. So now the two classes of local anesthetics, starting with the esters. Here's an example, procaine. You can see the ester linkage here, with this little oxygen and the double bonded oxygen over here. Here's an example of an amide, ipivacaine, and you see the double bonded oxygen and the amine here, making this an amide linkage. And in both molecules you can see the benzene ring, making the lipophilic nature of this drug, and then you see the tertiary amine over here, and here's the tertiary amine. But notice how they're different. You know, this tertiary amine has a cyclic alkyl group, and even the benzene rings differ. This benzene has two methyls coming off of it, and this benzene even has a nitrogen group off of it. So this is the basic structure of local anesthetics, three parts: the hydrophobic group, the linkage, ester or amide, and the tertiary amine, which gives the local anesthetic its basic properties. So there are different types of amino esters and amino amides, many different drugs to choose from. One helpful way to help to remember which is which, the amino amides tend to have two eyes, so one eye, second eye, one eye, second eye, just a quick trick. So now getting into the acid-base physiology here. The pKa of the physiologic environment is 7.4, which is slightly basic, but you also have to keep in mind that these local anesthetics are weak bases, and the pKa of the local anesthetics tend to be much higher than the pH in the local physiologic environment. And because of this, they're essentially excess hydrogen ions for this local anesthetic. And these excess hydrogen ions push equilibrium such that the majority of the local anesthetics are in their protonated form. Okay, and as the pKa is higher, it's further from the physiologic pH, and more of the local anesthetic is protonated. And this presents a problem as the local anesthetic needs to be non-charged in order to cross the lipid bilayer. So there are a few situations in which the environments are acidic, which make it even harder for the local anesthetic to be in its uncharged form. If you inject local anesthetic into an area that has local acidosis, say the tissue is infected or ischemic, this local acidity causes more of the local anesthetic to be charged. Also, the packaging from the pharmaceutical company tends to be acidic, pH of 6 to 7, and this causes more of the local to be charged. And furthermore, if you have epinephrine in your solution, in order for the epi to be stable, it needs to be in an acidic solution, often with a pH somewhere between 4 and 5. And this is 2 to 3 orders of magnitude below physiologic pH, and it's going to push the majority of the local anesthetic into the charged form.